attract the adrenaline junkie and trying to attract this lights and sirens, blood and guts mentality. Because I never went into it wanting, I mean, of course we all want emergencies and lights and sirens and everything. It's exciting, and those are the most critical calls. But for me, I'm results driven. I want the result. So if you can't breathe, I want to make you breathe. If you have an appointment, I want to get you there on time, basically. So a successful call for me is one that what was needed was done. Mm-hmm. And yes, there are exciting calls with lights and sirens, and you get great results with that. And actually, sometimes the ones that are lights and sirens, you don't get results. They're too critical to fix. There isn't anything for you to do. People always say, oh, I love trauma. You don't do anything on trauma.
You plug a hole and you step on the gas.
And that's you drive.
It's petrol.
Yes, there's more details than that. I apologize.
But it's the medical calls, the specialty transports, a lot of the social work we do. You're going to laugh when I quote Third Watch, but we're problem solvers. That's what it is.
You're right, she laughed.
We're professional problem solvers, and it's not always a medical problem. It's a social problem. It's a educational problem. It's a hunger problem sometimes.
I think you're really saying it, though. You really are evidencing the generation.
Yeah.
Because our generation of medics were not taught about lifelong education.
No. Not taught about problem solving. In other words, we were
told to get 40 hours of CE.
There you go. We weren't the street therapists. See, now the realization is that you do provide that type of street therapy, those networks in, and that's where EMS I see evolving to. Back in the day when Jim and I were there, honestly, they were happy if you just showed up for work. They really were. You're talking $3 an hour, talking $5.25. In Sacramento, when I first started, 30 days later they implemented gloves, and then after that, we were EMT2s. And if you were a paramedic, there were like 4 ambulance companies in Sacramento, you could start the next day. They just said, you got a paramedic card? Can you work tonight? And seriously, that's how it ran. What size is your shirt? Get on the ambulance. It was really that way. And it was one of those things to where now EMS is evolving to that point 20 years later, for me, I've started that it's becoming more and more of a profession, in the private sector and public. And when you talk about, we could see the differences of the evolution. When you talk about we are problem solvers, we are street therapists, you are. Back in the day, we were the worst street therapists. What did we do? Get in the box, let's go to the hospital. I don't know what your problem is, get in, let's just go. And now it's more of, hold on a second, what's going on? What social services can I give to you? How can I assist you in that way? And that's the gap that we're beginning to bridge now.
What's going on, and then sort of bridging into community paramedicine and some of the ways that my system has operated, which we've touched on before, is it isn't get up and go. It's, let me hook you up to the monitor. Let me ask you some questions. Let me actually find out what's wrong with
That's
you.
what we teach you now.
And then let me decide what hospital you need to go to, if you need to even go to that hospital, what we can do to help you. And in her system, partly because of the distance between hospitals, you just want to pick some up and go, and you'll do all your diagnostics en route because 99% of the patients are going to end up at that hospital anyway. And I'd come in and say, well, no, I need to make base. I need to find out what's wrong with you. Maybe you have a STEMI. Well, let me call the 3 STEMI centers that I have and see what they want. And we're going to really kind of like tailor our care to you instead of just giving a ride.
Now, you did mention something very interesting, that now we're starting to become clinicians. We're starting to be, we have all this technology to capture pretty darn detailed assessment in the ambulance or even in somebody's house, but we're still locked into this old system of the ambulance is to take you to the hospital, not to help you in your time of need necessarily. What you need is a ride. I have one, however, you don't need this fancy of a ride, And so we're starting with making our clinicians better. Now we need to make the systems better utilize those clinicians.
One of my finest partners was 9 years my senior, same school. I went to school down in Los Angeles. And this guy was a nurse in the Army. And he had that mindset already. And he's trained hundreds of paramedics now. And he's trained people in your generation of paramedic, and he's also trained paramedics in my generation of paramedic. And I can tell you that those people don't burn out because they have a zest for finding the next educational outlet. Where can I learn more? And that's the key to staying fresh.
Yeah.
Understanding that you need to keep learning.
Because medicine changes every 5 years.
Every
or
day,
Every day.
medicine changes. In evidence-based medicine, we are disproving everything that was in my EMT book.
Absolutely. And I think,
Oxygen
yeah.
Well, not
being
yet.
questioned. Backboards being questioned.
Collars
Everything we've been
being
doing being
questioned
questioned.
big time
Sure,
right
yeah.
now.
We talked about RSI today. What,
Should we let you do it or not?
Yeah.
right?
There are very dangerous side effects to some of those
That
drugs, and then
1%.
I have to teach you to treat that 1%. But a drug that you're only going to use 1% of the time, but you're going to use this drug 50% of the time on all these head injuries, maybe I shouldn't give you the RSI. Maybe I should give you a King tube. Amazing. An awesome BLS airway. Get you to the hospital where they can give that extra little bit of drug, and if the drug is that, if they are that 1% that reacts to the drug, they've got the antidote and know how to use it. And you had an airway all the way in.
Right.
Ta-da.
It was it was
But it's-
pre-glottic, but it's still an awesome airway.
It's thinking past that, a lot of the verbiage online right now is not intubation,
BLS airway.
ventilation.
Yeah,
Yeah.
just
Our
get
job
the
is
air
to
in.
our job is to assist gas exchange. However that be.
It's VOP.
I'm a big fan of how's the bag? Good. Done.
It's VOP. It's ventilation, oxygenation, and perfusion.
Exactly.
And that's what you
And
need
nowhere
to worry
in
about.
there
Those
is-
are your true ABCs.
There's no tube in there. There's no fancy tools, no color changing anything. There's
You in a bag and watching a chest do this.
That's
Yeah,
where the
all
generation
you
comes
need.
in, where the adrenaline ego says, I want the tube, because I can brag about the tube. Where I say, I want an airway, because I want them to live.
Bill can confirm this.
Yeah.
All the EMT2s in Sacramento used to introduce themselves. Bill Sugiyama, 19 Craigs.
Yeah. It
Because
was.
you got one shot at a tube and then you had to stick a needle in the neck.
Yeah, and not only that, it was one of these things to where we had drugs and we were pushing drugs, but then when you asked a simple question of why did you do that? Well, because it's in my protocol,
Protocols said to.
very cookbook, and there was never that expansion on the knowledge base. I think what we're hitting into now is, as you've seen the new phase over what I've seen over the last 5 years, I would say for myself, recognize it may have been longer, is that EMS is becoming more evidence-based. Okay, is the thing is, and also we're being included in many studies, and
that's the important part.
paramedics are beginning to evolve to where we're becoming more educated, and this is why, if anything, if I could use this forum to say it, I advocate that every EMT and paramedic, regardless whether you stay in EMS or not, continue on with their education and become educated, because we are at the same stage. Here's the example. The nursing profession has been around for how long? Over 200 plus years. Remember where they started off as criminals and prostitutes, okay? And so they've evolved to this point where they are all educated now at this level. And this is where we need to bring EMS up to for that credibility, and also to increase the knowledge bases, to be involved in research and evolve our profession. If you notice now, it's no longer door to balloon, it's EMS to balloon. You see that? Or cath. All that. EMS is being included in every type of care now, because we make a significant difference in patient outcome. And that's what they're realizing.
But the studies need to focus on, everyone likes to quote cardiac arrest survival. And that's a very easy study to go. We can go, they lived or they didn't.
That's because that's the only thing that you can definitively say. We either did something good or we did something. The patient either got better or got
they
worse.
didn't, and that's
everything
unfortunate.
else is subjective.
It's unfortunate because they don't factor in the trauma care or the asthma cases or the field analgesia or all these things that isn't going to necessarily save your life in the end, but it's like, how do you quantify comfort? It's a very difficult thing to manage. And we can just look at an asthmatic patient and say, well, I gave you relief for 5 minutes while we went to the hospital, but are those 5 minutes of wheezes that I removed going to help you out? How do we measure that? By saying, well, today we're not going to treat asthma. We're just going to give them oxygen and drive. And then today we're going to try this new other drug. We can't. I want to get those results, but I don't want to have to withhold treatment that I know is going to help. And I can't say it helps in any sort of statistical manner, but I know it helps because I see it help.
All right, well, you
that's,
can carry this to the education side too.
Mm.
Because you know that, not to make it boring and about, all the physiology of it, but every beta-2 specific bronchodilator side effects will include wheezes.
Mm-hmm.
Did you make them worse?
Right.
No.
No, I didn't.
You made them better because you opened it up more so we could hear more wheezing.
Yeah.
And you know what? You deliver them to ER, what am I going to do? I'm going to give them more of that same drug, and I'm going to give them steroids.
Right.
And then possibly give them some to take home.
Exactly.
And then when they run out, they'll call us back.
But you know what? That may happen, and probably does in a lot of the inner cities that we have in this world, and that's because EMS is its primary care, which is a totally unfortunate situation. But at the same time, you recognize that you understand respiratory physiology even better today than you did a long time ago, and now you've seen it work. And you have this zeal to make the guy that can't breathe or is emptied out his albuterol and has been trying to breathe hot water that turned cold. You fix something for him.
Right. You want to.
We can't really quantify that, but at the same time, we keep statistics on how many people you've treated that way in the field.
But when services look at, because a lot of services are saying, well, is ALS really necessary? Can we just downgrade to an advanced EMT system, or do we need more paramedics versus EMTs? And they look at the cardiac arrest survivability, not all those other ALS treatments and ALS therapies that are benefiting the patient.
Take it one step back. All those ALS assessments.
All the ALS assessments.
That
get the
educated,
patient.
trained eye going in and saying, well, I know your blood sugar is 59, and I know you're 1 point away from not having to be treated. Tell you what, I'm going to stand in the corner. You have some orange juice and a turkey sandwich. I'm going to check your sugar again in 10 minutes. Is that outside of protocol? Not yet.
Not
Is that the
yet.
right thing to do by your patient?
Sure.
Yes.
Yes.
So not necessarily, I mean, I don't even have to start a line on that patient to make a positive difference based on my medical education.
In every system I worked in, I'm guilty for fixing somebody food
Yep, absolutely.
and then signing them out AMA because that was the only mechanism I had to leave the diabetic at home.
Yeah.
It really isn't against their medical advice to stay there.
No.
Yeah.
And other systems now have mechanisms where you can sign them out.
So
But you know what?
Wait.
Recognizing, I was so excited when the new EMT curriculum came out and the physiology was 3 times thicker in the
Oh, yeah.
book. Because you deserve to know the physiology.
Just when I was in EMT school almost 5 years ago, that's what it was. It was give oxygen, but you're not allowed to know why. And
And
even,
that really
and even
bothered me. And when I taught EMT school, and I've been teaching EMT school for 13 years,
Mhm.
that really bothered me. And I used to tell my students when they came in refreshers and they came into the class, I was the guy in the classroom that go, why?
Yeah.
And I get told every time, because we say so.
Because we say so.
Yeah.
And you know what? I didn't want to give that answer.
I think what I appreciate that I see here is, and we've seen this paramedic, because like when you're in your ACLS class or when you've done those courses, you're in that one medic, you're like, okay, well here's the deal. This is why. Do you see the significance of why you need to be able to tell the difference between diverticulitis or appendicitis and so forth, and then the
Absolutely.
response that used to kill me like a dagger in my heart all the time from a senior medic or any medic is like, well, what's the difference? It's not going to change what I'm going to do. Why do I need to know that? I don't need to know that. What my treatment, what am I going to do? I'm going to start a line and just take them to the hospital. Why do I care? Why do I care whether it's this or that? And so that's the mentality that I advocate that we all fight against, because that is stopping the evolution of our profession significantly there. And I think, as listening to you talk, when you speak of the next step, and if you think about this, I mean, EMS really was, in the beginning, like the first level of social media, because you were forced to go ahead and socially meet and talk to people like you just talked about, and as far as it goes. But in the other aspect, when Jim talked about, I sat back and I made a sandwich for somebody. Well, what are we entering into? That's the next evolved level of EMS, of community healthcare,
Right,
community
and it
service.
naturally comes.
Yes.
Nobody wrote a protocol that said, you know what, if they're conscious but they're hypoglycemic, let's try these therapies. We just evolve that of ourselves and say, no, this is a better way to fix that.
Yeah. It's
And-
the bologna sandwich protocol. Didn't you know that?
Right,
You know?
but there wasn't a committee that decided
Sure.
this is how we're going to treat this type of patient. It came from a trained provider who knows his patients and knows his community and said, well, this is better, and you don't need a hospital bill, and I don't need to be out of service, and you don't want to go anyway. And
It's
Yeah.
absolutely one of those things I learned from working with that nurse. And he is still in the field now. He's got 33 years as a paramedic. He started in 1970. What is he now? 40 years, I guess.
Yeah.
I'm bad at math.
Yeah.
That's why
That's why he became a physician.
Right,
We
pharmacists
understand. We
take
know.
care of the drug dosages. So, his hash marks go all the way up his sleeve. They make his sleeves.
he
and
has
his
to wear a
dress
long
uniform.
sleeve whether
Yeah.
he wants to or not.
So, I mean, this guy, he said, everybody doesn't need to go to the hospital. And we're going to learn why.
Well, you look at the name. We're paramedic. When they say you're an extension of the hospital, you're an extension of the physician, well, let's start acting like one. let's be an extension of that physician.
I don't
They
want
say-
you to be me at my extension.
No,
I
you don't-
want
you
you to be a caregiver.
Our
I
own
want you to be
clinicians.
a primary caregiver in the field.
Right.
Yes.
You deserve to be your own caregiver. You don't deserve to be my extension.